I'll introduce myself for those who may not know me. I'm Nandini. I'm one of the haematology consultants at Manchester Royal Infirmary. Firstly, I'd like to take this opportunity to thank all of you for taking time to attend this session. I'm hoping this will be the first of future short clinical series for healthcare professionals, just to increase knowledge on red cell disorders. For Dr. Noémi Roy doesn't need any introduction, but for those who may not know her, she was trained in Edinburgh in medicine and did her haematology training in London and Oxford. Her main area of interest are hemoglobinopathies and inherited rare anemias, and in particular, genetic investigations of inherited anemias, including whole genome sequencing. She's involved in the investigation and management of iron deficiency in diverse patient groups. She's dedicated to using patients' views to guide how research is conducted in hematology and coordinating best practice care in red cell disorders at European level. Noémi also leads on quality of life studies in sickle cell disease, as well as looking at novel ways of improving compliance, patient understanding, and patient pathways for high quality care. Finally, she is the NHP lead on rare anemia. Thanks, Noémi, for making time today. We're going to have two topics that we're going to cover. We'll start off first with Diamond-Blackfan anemia, and then we followed by congenital dyserythropoietic anemia. You can put your information or questions on the chat box, however little or small. The aim of the session is really to have a discussion. There's nothing as a silly question, so please ask if you don't know. Over to you, Noémi.
Thank you, Nandini, and thank you all of you who've dialed in today. It's a real pleasure to be here. And Nandini, when you say thank you for taking the time, on the contrary, this is exactly the kind of thing I like to do. So it's a real pleasure. As Nandini said, we have everybody mute at the moment while we do the talk, and then we can have questions at the end, because there's a little bit of noise that seems to be affecting the quality of the sound. Okay, so I've got I'm going to share my screen, and I've got a very tiny introduction, and then I'll do the two talks. So the tiny introduction is here. So this is what we're going to cover: who, what, when, why, where, and why. I just wanted to say that one thing I'm not talking about in detail today is next generation sequencing. And if you want me to do another session about that, I'm very happy to do so, because this is, a fairly new technology that we are using more and more. And I've put it here. We've got some guidelines coming out very soon in the BSH, and this is one of the figures from the guidelines about how we use next generation sequencing in rare anemias. And it's just one thing that we use in the context of obviously the history, the examination, the blood tests, bone marrow, and specialized tests. And this is what the machine looks like. And the reason I wanted to give you some background, Nandini did say that I'm very interested in how we investigate these anemias. And I started in 2012 with this rare anemia panel, and the only other place that was doing it in the UK was in London. So since 2012, there's only been two places you can get these tests done, but it's fairly expensive, and provision across the UK was very unequal. So NHS England set up these GLHs, these genomic laboratory hubs. And there's 7 genomic laboratory hubs, and of those, they've bid for the business to basically provide rare anemia testing, and 4 of them have received it. So now we've got these genomic hubs. We've still got Oxford and London, but we now have Manchester and Newcastle as well. So we've got 2 new laboratories that are testing for these conditions. We're all using the same test, so it's the same genes that is being tested in these 4 different places. This is now commissioned, which means NHS England pay for it directly, and we no longer have to ask individual hospitals to pay for it, which means we've got equal access. And we're hoping that a lot of patients who've been, even if been in clinics for many, many years with the diagnosis, if they haven't got their molecular diagnosis, we're hoping that they're going to start to access that. we're really doing shared working, because the expertise that we've developed over the past sort of nearly 10 years now in London and Oxford, we share that expertise together, but also with the two new centres. So we have joint MDTs and we have joint meetings to make sure we're all learning from each other. And then most importantly, we want that to improve care. And so one of the things I can come back to later, but one of the things we've developed, I also run a charity called Congenital Anemia Network. And in conjunction with another charity called DBA UK, we've put together a genetic passport for patients. So we're trying to get also patients to understand better what their molecular diagnosis is and why it's important. So now I'm going to talk specifically about Diamond-Blackfan anemia. So we'll get those slides up. And slideshow, here we go. So this is a picture of a little girl who's got DBA, and there was a story about her in the Mail online in 2018, and she was going to go for a bone marrow transplant. So it's actually something that some people in the general population will have heard of, but generally when you speak to patients and families with these rare disorders, whether it's DBA, CDA, or whatever, they struggle because how rare it is and how few people know about it. Now, you might think it might be normal for people in the street not to know anything about it, but is it really normal for your GP not to know anything about it? Well, possibly. A GP can't know about every single rare condition. But once you start thinking about, is it normal for hematologists not to know anything about it? You know, an individual hematologist may only ever see 1 or 2 cases in their whole career and sometimes won't see any. And there's nothing worse for a patient to hear a hematologist say to them, you know more about this than I do. And of course, it is often true that the patients know more about it, but patients need to have confidence that their clinical teams, if they don't know about a rare disease, know how to get information and are interested to learn about this condition so that they can really support the patient and their family. So I'm just going to go through how it presents, how we diagnose it, a little bit about the genetics and the pathogenesis, how we treat it, very briefly about new therapies, and then prognosis. So I've just said it's a rare disease. What does that even mean? So how do we define a rare disease? A rare disease is one that affects fewer than 1 in 2,000 individuals. But actually, you've probably heard these statistics on Rare Disease Day on February 28th. There's an estimated 7,000 rare diseases in the UK. So in fact, if you're out walking outside or you're at the supermarket, 1 in 17 individuals actually is living with a rare disease. And in total, we've got 3.5 million affected individuals with rare diseases in the UK. And DBA itself is about 1 in 100,000 or 1 in 200,000. And I'm a very visual person, so I have to sort of imagine, what does that mean, 1 in 100,000, 1 in 200,000? It's basically like 1 hair out of a full head of hair. Okay, so that is pretty rare, and it's not that surprising, therefore, that not many people know the details about this condition. So the main things about it is that they tend to present early. The red cells tend to be big, and there tend to be very few reticulocytes, so those little baby red blood cells we see in the peripheral blood. They often have associated defects, such as cardiac defects, and if you look at the bone marrow, there's just no red cell production. So most people will present about 8 weeks of age, and most of them have been diagnosed by 12 weeks. In fact, more than 90% of the reported cases present clinically by 1 year of age. Okay, so if you look here, you've got the age in months. So this is really babies. And so there's a big peak right early on. But actually, this is basically 10 years old. You're not seeing how many people are presenting beyond 10 years old. And because I showed you that we now have much more availability of these genetic tests, and because we test all the rare anemias in a single test, we're finding more and more adults who didn't know they had DBA, who've got a milder form, and now popping up in their 20s, 30s, 40s. I've even seen somebody present in their 50s. So this is something that's going to change, and is going to require us to really grow our skills. So how do we diagnose it? Well, the anemia is moderate to severe. There's usually normal white cells and platelets. Almost all of them, 75 to 90%, have a high EADA, which is a very specialized test. Only a couple of labs do it in the UK. And we have no idea why it's abnormal, but it tends to be high in DBA patients. They also tend to have a slightly high hemoglobin F level and high EPO level. Not only is this EADA test need to be done in a few select labs in the UK, but also it needs to be done on fresh blood, stored at 4 degrees, less than a few days, etc. So it's not that easy to get that result. Almost all patients will go on to have a bone marrow biopsy, and quite often when you speak to the families, it's a remarkably familiar story where they say they had a baby who's really struggling to thrive. The mum goes to the GP repeatedly saying something wrong with my baby. The GP says you're just an anxious mother. The mum goes back, and finally the GP does a full blood count, sends it off. Then the patient's mum gets a phone call to say you must present to A&E immediately. Your baby has something very serious, probably leukemia. They end up in A&E, end up having a bone marrow, and then they find out that it's not leukemia, it's Diamond-Blackfan anemia. The stories are incredibly similar between patients. And if you go, I've been to a DBA UK weekend. It's almost the parents have almost pride in how low the hemoglobins were, and I think the lowest we've heard was something like 25 or 30. They just extremely anemic. But basically, when you look down the bone marrow biopsy, there's just very few, if any, red blood cells being developed. So some of the babies will present earlier because they'll have other abnormalities, like you can see here, triphalangeal thumb, or they'll have a cleft lip, cleft palate, or they might have cardiac abnormalities. Sometimes the cardiac abnormalities are not immediately obvious and you can only see them on an echocardiogram. When a really small baby presents like this, we can think of DBA, but there's other things it could be. So one is parvovirus, which is a fairly common virus in the population, and in most people will just cause like a cold and general tiredness. But in people with DBA and people with hemolytic anemias can essentially wipe out their red blood cell production for a short time. And then there's something called transient erythroblastopenia of childhood, which nobody knows why it happens, but essentially your bone marrow stops producing red cells and then it starts again. So what about the genetics? I've got here the list of a lot of the genes that have been found to cause DBA. And if you look at the names, this is the commonest one is called RPS19, and that covers 25% of the people who have DBA. And then you got RPL, RPS, RPL, RPL. This means the ribosomal genes subunits, either S for small or L for large. And essentially, DBA is a autosomal dominant condition where you have a defect in how bits of how the ribosomes are formed. Now here at the end, we've got some non-ribosomal protein genes, TSR2, GATA1, and EPO, and I'm not going to talk about those, and there's a lot of debate about whether that's true DBA or not. So I've said it's de novo. I've said it's dominant, which means that you only need one abnormal copy to have the condition, but actually 50% of them are de novo. So that means mom doesn't have it, dad doesn't have it, but the baby has it. Okay, and that could either be because the baby's developed it during in the womb as the cells were dividing, or sometimes it means that the mutation has developed in either the sperm or the egg of the parent and doesn't affect the rest of their body. But it's not because it's dominant that that you would express it. So for example, there's something called asymptomatic carriers. So you could be, once we find a child who's got DBA, we test the parents and siblings, and sometimes we find that one of the parents has it. Some of those parents are completely normal full blood count, normal bone marrow, etc. Sometimes they're actually anemic, but they didn't know it. Or sometimes they have, if they have an echocardiogram, we can find that they had a very small hole in the heart that doesn't affect them clinically. Now, it's really important that we find these cases, especially when we're talking about doing a bone marrow transplant in a DBA child, because you really don't want to give them as donor a sibling who's actually got the mutation as well. So why does this arise? What's the pathogenesis? So I've got a little cartoon here of how red blood cells develop in the bone marrow. So they start off as hematopoietic stem cells, and then they sort of commit to becoming red cells, and then the more they commit, the more they become differentiated, and then they really multiply and produce lots and lots of reticulocytes and finally red blood cells. And as I said, when you look in the bone marrow, you don't see any developing red blood cells, and that's because essentially they all die extremely early. So why is that? Well, this is a very complicated slide, and you don't need to remember any of this detail, and I certainly don't remember any of this detail, but it's just to show you how ribosomes are formed. So ribosomes is where we translate our messenger RNA into protein. So it's like the factory that takes all the information from your DNA and turns it into a product, the protein, and it's just a very complex thing where it starts off as 90S ribosomes, and then you've got pre-40S, pre-60S, it turns into 60S and 40S and 60S. And basically what that means is that if you've got a defect anywhere along this pathway, the ribosomes, the factory that makes your proteins, just doesn't look right and doesn't work properly. There's some evidence that all of these different ribosomal protein mutated cases converge on GATA1 undergoing an abnormal translation. And GATA1 is the most key transcriptional factor that controls erythroid red blood cell development. It seems that P53 is activated in the DBA erythroid precursors, and P53 is one of these proteins that's elevated to tell the cell to kill itself because there's something wrong with it. So obviously, if you imagine red blood cells developing in the bone marrow, and for some reason the P53 level goes up, those red blood cell precursors are just all going to kill themselves because they know something's not right with them. And then we have some evidence that leucine, which is an amino acid, it's something you can buy at Holland and Barrett's, and some DBA patients take it, that it can actually improve the ribosomes that are to make them work better and improve this GATA1 transcription. So anyways, this is kind of the hypothesis of how DBA arises. What about treatment? So the first thing we do is we transfuse the patients for the first year of life. We don't chelate them because chelation is not licensed for children under the age of 1, and it can in fact really damage the growth plates. Now, DBA children are usually very small already, and so adding chelation would make things worse. So they basically just receive transfusions for the first year of life. They then have a trial of steroids. Again, we don't give steroids to very small babies because it's very bad for their growth. But once they've got through the first year of life, they go on to a trial of steroids for 4 weeks. And 80% of them respond to steroids. But actually, not all of them will continue to respond to steroids. Of those, about half of them carry on with steroids, and then half of them have to stop. There's a certain threshold, like if you can respond to a lower dose of steroid, you can stay on it. If you need the full high dose of steroids, basically the clinicians think that the risks outweigh the benefits and you should come off the steroids. There's some thoughts about whether particular steroids work better, prednisolone or hydrocortisone. That question's not entirely resolved as far as I know. But essentially, if you don't respond to a low dose of steroid, well, a tail down dose of steroid, you either get considered for a transplant or you go back onto lifelong transfusions. Now, if we look at the patients who are receiving transplants from the DBA registry, overall survival is about 77%, but the survival is better if the children are younger, so age 9 or younger. It's better usually if it's from an HLA matched related donor, but actually survival for matched unrelated donors has gone up. So in 1994 it was about 32%, now it's about 85%, so that is improved. What about new therapies? So there's a few trials that are open for DBA, although I don't think any of them are open in the UK. One is leucine, which I told you is an amino acid, and you don't actually have to have to be on a trial to have leucine. You can just buy it from Holland and Barrett, although it can require it can be quite expensive, but it's thought to increase the translational efficiency and basically help the red cells not to kill themselves and just to stay in the bone marrow, continue to mature and come out in the peripheral blood. And then very strangely, there's a drug called sotatercept, which is usually used in cases of ineffective erythropoiesis like myelodysplastic syndrome or thalassaemia, that has shown an effect in DBA preclinical studies. So I have seen a trial in the UK that's open and that's using that. What about prognosis? So again, looking at various registries, the median overall survival is 58 years, and that is obviously not brilliant. 75% of them are alive at age 40. Pregnancy is a particularly vulnerable time for DBA patients. We've obviously got to think about, because it's a dominant condition, the risk of the baby being affected, but actually the mum herself, as she's going through the pregnancy, can have a lot of complications. And so it needs to be really managed in a specialist unit. But most importantly, because DBA affects these essentially affects ribosomes, which is absolutely critical to how cells work, it actually is a cancer predisposition syndrome. So they have the risk of getting cancer is basically like 5 times more than the general population. And the most common malignancies are myelodysplastic syndrome, acute myeloid leukemia, colon carcinoma, osteosarcoma, and genitourinary cancers. So in fact, looking after DBA patients includes things like trying to do surveillance to try and catch these cancers early. So some people will have a yearly bone marrow to look for developing MDS or AML. Some people will have it every 2 years. Some people won't be having regular bone marrows, but they'll be having things like a myeloid panel. And there's talk about, when should they start having colonoscopy, etc. So, and the other thing I was going to mention is if you have a hematopoietic stem cell transplant, yes, it will solve your transfusion-dependent anemia, but it doesn't help at all your risk of cancer. In fact, it may increase it because we're giving chemotherapy. So what do people die of? Again, using a DBA registry. 70% are treatment related, so infections, complications of iron overload, vascular access device complication, and then stem cell transplant. There's some 20% are directly related to the DBA, so 1 died of severe aplastic anemia and 7 from malignancy, and then there's some undetermined causes. Any questions, you can email me. Right. So that was the first talk, and then I'll do the second one about CDA1. So the idea is really that I'll give the 2 talks, and then we'll have a fairly good chunk of time left for Q&A, which is much more interesting than just someone talking at you. Okay, so now CDA, congenital dyserythropoietic anemia. By the way, Nandini, I thought that was excellent pronunciation. I often trip over the word dyserythropoietic, never mind spelling it. So what does it mean? Congenital means you're born with it. Dyserythropoietic means it's an abnormal shape, and anemia, as we all know, is too few red blood cells. So the first question is, again, this is a rare disease. In fact, we probably would call this an ultra-rare disease. There's very few epidemiological studies for any of these rare diseases. So there's a few people who've tried to sort of count up all the cases. This is an old paper from 2010. And you can see, for example, there were 36 cases of CDA1 and 29 of CDA2 in the UK at that time, although we know about more now. Some places seem to have higher numbers. Look at this one in Italy, there's 146 of CDA2. Now, when you find a place that sees a lot of cases of a rare disease, you've got to ask yourself 2 things. One, is there what we call a founder effect? So did that gene arise in that population? So if it's arisen in, I don't know, Milan or something, then obviously you'll have more and more of it spreading locally there, and then you'll have fewer spreading in other places in Europe. The other question is there just like an interested doctor who's doing lots of screening and looking for these cases? Because obviously the more you look, the more you find. But basically it's a rare thing. Now, we've done a lot of genetic studies in CDA1, so I work in conjunction with a research group here in Oxford who are very interested in the genes that cause CDA1. And based on the mutations that we find and comparing them to how common they are in the general population, and that is something we can work out from huge database studies. So you can access hundreds and thousands of people's genetic results, whole genome sequencing genetic results on public databases, and you can see how frequent a gene is. And so based on the frequency of all the different mutations we found, we would expect to see about 400 cases of CDA1 in the UK. So this is 400 cases, okay? And in yellow are the ones we know about. So that's, again, an estimate. I know how many, because they're so rare and this is what I'm interested in, I will know about a lot of patients all over the country. And so we know probably about 60 of them. But that still leaves a lot of people with CDA1 who don't know they have it. So it makes you wonder why. Firstly, is it just that actually they've got a very mild version and they don't know they have it because they don't even know they're anemic? Or could it be that they've got a very severe version and in fact they're transfusion dependent, but nobody's worked out why they're transfusion dependent, and so they just keep getting transfused and they get told they have some sort of funny inherited anemia that they haven't quite worked out. But I am hoping that as we do more of these genetic tests, we can get some of these answers. So congenital dyserythropoietic anemia, see, I've just stumbled over it. There's different types. Most people know about type 1, type 2, type 3. There's type 4, type 5, possibly type 6, and then there's lots of untyped ones. Really, because it's such a descriptive thing, it's best if we just kind of group them by the genes that are affected. So CDA1, when we look in the bone marrow, the thing that we see are these internuclear bridges. You can see between this nucleus and this nucleus, there's actually a link. In CDA2, we tend to see more binucleate cells, so red cells with 2 nuclei. And CDA3, I think nobody could miss CDA3 because it looks so incredibly bizarre, and I have never seen a bone marrow with CDA3. You can have up to 12 nuclei in the same red cell. Now, the thing about dyserythropoiesis, it's just a descriptive term. It just means that the red cells don't look normal. And for those of you who saw this paper by Barbara Bain in 2018, what she did and the group of people she was working with, they tried to find out just how reliable these abnormal morphology were, and do hematologists all agree about these findings. So they picked 7 hematologists. There were 3 CDA cases, some normal bone marrows, some B12 deficiency, arsenic toxicity, and iron deficiency, and then some MDS cases. And then they gave each of the hematologists a description so that everybody would agree about what exactly we're talking about. So, for example, this is internuclear bridging, this is intercytoplasmic bridging, this is karyorhexis and basophilic stippling, binucleate, trinucleate, etc. So they sent all these pictures around, gave the description so everybody could agree about what is what. And then they sent each of those hematologists 2,000 pictures of erythroblasts mixed from these 20 cases. Now, for those of you who do look at bone marrows, you will probably be appalled by the way they've done this, because obviously when you look at a bone marrow, you're not looking at erythroblasts in isolation, and you're looking at the whole context of everything, and you would want to know the cellularity, you'd want to know how much erythropoiesis there is, you'd want to know for each of these abnormal looking cells, is it the only one you see or are there lots of it? So yes, this study is very flawed, but it's still really interesting that if we look at the concordance, so all 7 hematologists agreeing on what to call one of these cells, basically only 12% of the samples, in the individual pictures, did everybody agree. So 6 out of 7 was about 20%, 5 out of 7 is another 20%, and 4 out of 7, 25%. So actually, these are very difficult things, and there's very poor concordance, I would say, between hematologists. They had 2 CDA1s and 1 CDA2, and one of the questions that they asked just from this is it MDS? Yes, no, or uncertain. So we've got 2 hematologists that look at a CDA1 and say it is MDS for 2 of the different samples. So very difficult morphology-wise. So a bit more about the condition itself. So it's autosomal recessive. It can present as a hydrop. So, a mother who's having a pregnant mother who's having a scan and gets told that actually something looks wrong with the baby looks very anemic because there's too much swelling, or it can be incidental and can get picked up in late adolescence. It's usually a macrocytic anemia, so the red cells are large, and again, we don't have very many reticulocytes in the peripheral blood. Essentially, they are like a non-transfusion dependent thalassemia. It's ineffective erythropoiesis. They tend to have a big spleen. They tend to have non-transfusional iron overload. We don't tend to take the spleens out, which I can discuss in the Q&A if people are interested. And then 20% of them have funny fingers and toes. And again, I remember seeing a patient with CDA1 and examining her and not taking her shoes and socks off. And in the end, it turns out she had very abnormal toes, and I would have missed it if she hadn't told me herself. So you must examine these patients really head to toe, literally. So what do we see? What's abnormal? So they've got something that we call Swiss cheese heterochromatin. Okay, so this is a bit of a joke slide, but essentially in a developing red blood cell, if we look at it under the electron microscope, we see dark bits which are heterochromatin, so that's tightly packaged up chromatin, and gray, light gray bits that are euchromatin, which is open and active chromatin. And in CDA1, you see these little holes, these white things throughout the black material. And we don't know why they arise, but it's the only thing that has ever been shown to cause this Swiss cheese, or sometimes we call it spongy heterochromatin. So what happens? Remember I said this. I don't have the same cartoon as I did for the DBA. But remember, for DBA, I was telling you that it was very early erythroblasts that were basically dying. It's very different in CDA. They don't die here. They keep making and making and making red cells, but something goes wrong along the pathway, and you have very few reticulocytes coming out, very few red blood cells in the peripheral blood, and so all of this fills up with immature red cells that can't seem to mature through the normal process. And we in the lab are able to copy what happens in the bone marrow, so we can take peripheral blood from patients with CDA1, well, any patients really, and we can differentiate them in the lab, and we can basically create just the red cell part of the bone marrow. And you can see that in the erythroblast of the CDA1 patient, we see that same Swiss cheese, see all these little holes. And that's from a cultured erythroblast, so we don't have to marrow these patients. What does that mean? What's happening in this chromatin? So chromatin is basically DNA that's packaged up around proteins, so it winds itself around proteins. And we think that there's something wrong with that packaging. And the reason I put this rare and common thing is that even though the point was that even though CDA1 is very, very rare, actually whatever goes wrong, it's going to be informative about how all normal red cells develop. And so we think that if we can find out more about CDA1 and what makes it go wrong, we'll be able to treat more different types of anemias as well. So we know about two genes that cause CDA1. They're called CDAN1 and C15or41. It's recessive, so you need 2 copies of the mutations. These are all the mutations we've discovered in one of the genes and then very few in the other. But there's no genotype-phenotype correlation. That means I can't tell you by looking at the mutation what type of CDA1 the patient will have. I can't tell you if it's going to be mild, severe, if they're going to need transfusions, if they're going to need chelation, none of that. And I want to say a few words about the treatment a bit later. But essentially, what we know is that whatever goes wrong with the molecular pathway, so in CDA1, I've explained it's probably to do with histone assembly. CDA2, I haven't shown you any details, but it's to do with vesicles trafficking from the Golgi apparatus to the endoplasmic reticulum. And CDA3 is to do with how when you copy your DNA, your chromosomes need to separate, and you basically copy all the DNA and then you turn it into 2 separate nuclei. Whatever the molecular abnormality is, there's a block in differentiation, and that leads to apoptosis of the cells. And so it's what we call ineffective erythropoiesis, which is exactly the same thing as thalassaemia. So I really like this diagram to explain all ineffective erythropoiesis. This is normal erythropoiesis, and this is the number of cells. So if you look at very early on in a bone marrow, you've got very few cells, and the more they differentiate, the more of the cells accumulate, and then they mature, and then they turn into red blood cells. In thalassaemia, in CDA, in myelodysplastic syndrome, because of the poor differentiation, you have very few normal red cells coming out. It drives your erythropoietin production, and it keeps driving this process. So you have a huge balloon of cells in the bone marrow, and that's why people get extramedullary hematopoiesis. So you might have seen people with thalassaemia. In fact, I think that's my next picture. Yeah. So people with thalassaemia, instead of having just a little bit of bone marrow at the ends of their bones, their entire bone will be filled with bone marrow. And that's the same thing with CDA. You'll be trying to make bone marrow in your skull, and that's what we call the hair on end appearance. And you'll be making bone marrow outside your spine, and it causes these masses that you can see on a chest x-ray. So all of this will also happen in CDA. In terms of the treatment, we have only one specific treatment, and this is one of my favorite stories about serendipity in medicine. So this is a 28-year-old French woman with CDA1 who was having monthly blood transfusions, and she developed hepatitis C from the contaminated blood. You've been hearing about the UK contaminated blood story recently in Parliament, but France had its own investigation a good 20 years ago, I think, and they had the same issues. So because she developed hepatitis C, she was given interferon to clear the hep C, and over the course of 6 months, she cleared her hep C, and over that time, she became transfusion independent. Now they stopped the interferon after 6 months because she'd cleared the hep C, and she became transfusion dependent again. So that was the very first time that anybody realized interferon is helpful to CDA1, and it doesn't help in CDA2 or CDA3. In terms of looking after these patients, I've put this for CDA1, but this is true for all rare anemia patients, and I would believe all patients altogether. It's basically a partnership. You've got the patients, the doctors, patient organizations, the nurses, etc. And it's about speaking to patients about their options. There's good diet, having folic acid, trying to prevent osteoporosis. Some of you will be looking at this and think this is exactly like thalassaemia, and you'd be right. Pastoral care, looking at patients holistically. XJADE, massive issue with iron overload, obviously for those who are transfused, but also the patients who are not transfused will also iron overload. And again, I can answer questions in the Q&A if you're interested. Managing the transfusions and not removing the spleen. So there's no good studies, but essentially we know that if you remove the spleen in CDA1, it does not help at all, and it can make some things worse. Here is one of my patients with CDA1 who has given consent to have her photo here. And this is her when she came to me in 2015, I think. And you can see her ferritin here. And she'd had XJADE, she'd had chelation, she'd had venisections, and she'd had interferon. So one of the really cool things about CDA1 is you can give people interferon to increase their hemoglobin so that you can then venisect them every month. So it sounds completely mad, but that way you're taking iron away. And when she came, she had iron in her heart and basically said she couldn't tolerate venisections, XJADE, or interferon. And we worked really hard together to get her ferritin under control. In fact, you can't see it here, but I even had to give her an iron infusion because we went a bit too far. She basically, we took it slowly, and it's about developing trust with your patient. And this is just an example of something I sent her. I'm a very visual person, but I think patients really like to see a picture and to show that something is getting better. And so I would always send her or give her a picture of how her ferritin's coming down to keep encouraging her. And I've put the rare common thing because obviously that's not specific to CDA1, and it's just chelation in general. Obviously, we need to think about mental health. So just having a chronic illness is associated with difficulties in mental health, but having a rare disease, having people tell you all the time that they don't know what you've got and that you should speak to your specialist and they can't help you. These conditions also have reproductive implications. Will you pass it on to your children? Will you be able to have children? Will your pregnancy be complicated? This is the genes we had on our panel. I'm not going to discuss that. No, I'm not going to discuss that. I wanted to show this because this is the conventional pathway of how we investigate rare anemias. We take a history, we examine patients, we send routine tests, we send off specialized tests, we do a bone marrow, then we tend to do the genetic analysis at the very end to confirm things. But my vision really, when I started the Oxford Red Cell panel, was that we could bring the genetic analysis much closer, and we could shorten the time to diagnosis. We could stop misdiagnosing people. So CDA1, a lot of people that have been diagnosed as CDA1 turn out to have PK deficiency, or some of them even have hemoglobinopathies, because what you see on the bone marrow is very non-specific. And if you look at my proposed NGS pathway, it doesn't include bone marrow at all. And I think it's unethical to do a bone marrow either in a child you've had to put under GA or an adult if there's no need for a bone marrow. Now, clinicians who look after DBA will will and do tell me that this is wrong, because with DBA you do need to look for any other abnormalities because of the risk of developing developing MDS and AML. And I haven't got the expertise with DBA. I don't look after enough patients to say whether I think that's right or not. So we have to defer to them. But certainly with CDA, there's absolutely no reason to do a bone marrow in somebody to confirm CDA, because we can do it all with these other methods. I mentioned sotatercept for DBA, which to my mind doesn't make sense biologically, but it makes complete sense in thalassaemia and MDS, where it's already used, and there will be a trial starting soon for CDA, although that's not going to be in the UK, it's going to be in Europe. Right, so I've shown you all my slides. I've talked a lot, probably too quickly as per usual, but I hope this leaves us enough time that we can answer questions, because I think that's probably the most fun bit for everybody.
Thank you, Noémi. It was a wonderful talk and a refresher for rare anemia, so thank you. I'll take the questions on the chat first, but please feel free to put your hands up. I think it should be quite a relaxed discussion. You can ask any questions you want to ask. Like I said, how little or simple it might sound, but you know, these are rare conditions and we don't see them very often. I've got a question from Indu from Cardiff. Hi, Noémi. We have an interesting case of an 8-year-old who was referred to us from genetics with a DBA mutation, who doesn't really have anemia, but moderate neutropenia. It would be nice to have your thoughts on this.
Yeah, so not everybody with DBA mutations have anemia. So certainly, if we look at the family members of people with DBA, we do see the mutation without anemia and with other features. Because, you know, I suspect that because we are testing more. For example, you'll be sending off the test for a cytopenia, and then we would be checking the DBA genes, which we wouldn't have done before. I suspect that we will see more of these and collect them. Now, some mutations, there is a little bit of a genotype-phenotype correlation with DBA, definitely more than with CDA. So some mutations, like I think RPL5 is more likely to have neutropenia, and I think it's RPL35A is more likely to have neutropenia. I always worry when people say a mutation, because what does that really mean? So do you mean a class 4 mutation or class 5 mutation where they've basically told you definitely we're sure that this variant is disease causing? Because we have to be really, really careful that we don't overinterpret genetic studies, and that if it's a variant of uncertain significance, we can't say that that's what's causing it. It could be what's causing it, but it could not be what's causing it. So by all means, email me and we can discuss it at one of our MDTs. We've started inviting people to our MDTs to discuss cases, so we'd be delighted to do that.
Yep, so the next one is overall survival you showed us for DBA for those who did get allograft. If so, what is the trajectory for DBA patients who do not get an allograft? What proportions get allograft?
Yeah, so the registry data I showed did include both. One of the issues with registries is like in the UK, I think there's more than one DBA registry. There's a DBA registry in Europe, there's a DBA registry in the US, and I strongly feel that we must put all the cases together. We must, and I don't just mean for DBA, we must give up ownership of our registries, because with these rare diseases, the only way we'll get those answers is if we put all the cases together. Now, obviously, the problem with registries is that we're always looking in the past. So, for example, I would say probably chelation is better than it used to be, and there's something very interesting about DBA. DBA chelation is more difficult than thalassaemia chelation. They need higher doses essentially, and I can explain that in more detail if people want. But we've got a better understanding of chelation. people are not, I think in the past they used to put steroids, they used to have lots of different trials of steroids if you didn't respond the first time, whereas now it's very clear. If you didn't respond within 4 weeks, you're never going to respond. So there's less messing around waiting for maybe there's something will happen. And the other thing I was going to say, the cancer surveillance is better. So I don't know, I don't have a number. I'm sorry if that sounds like I'm evading the answer, but I don't have a number to give you for the survival in people who don't have an allograft. But I think things are getting better because the care is getting better.
Yeah, I'll come back to the recording at the end. How do you manage the transition between pediatrics and adult services?
So it's a challenge like everything else. I'm working with DBA UK and some of the DBA patients to draw out a patient journey map around transition. So what the families say is there's the standard things you might expect about transition for children. It's like thalassaemia. You're going from a nice unit where you go straight into the ward if you're not well, and where you have your transfusions with lots of toys around you, to suddenly the adult unit where you've got lots of old people on chemo and nobody speaks to you or anything. So that's quite, or you have to go to A&E if you're not well. So that's kind of the same as with thalassaemia. What's different about this is a lot of these patients will be under a lot of different services. So with DBA, you'll often be seeing an endocrinologist. There'll be growth issues. You might be under cardiology. A lot of people have gastric issues. You might have mental health issues, and so the transition is extremely difficult because nobody seems to be taking an overall view, and each service is doing its own thing. So I would say the critical thing about transition is to identify a link person. And it doesn't matter who that link person is, and it doesn't matter if it's the endocrinology specialist nurse or the hematology specialist nurse or the DGH hematology consultant. The key thing is that early on you work with the families and you have a link person who's going to basically be taking charge of all the transition. Now, in terms of the other thing that's very difficult is with transfusions. As a child, you're receiving a number of mils per kilo, and then as an adult, you're receiving a number of units. And if you go onto a transfusion, a day unit, you've got whatever random hematology registrar is covering the day unit that day, prescribing blood, and forever saying you don't need 3 units because your hemoglobin is 90, and so I'll just give you 1 or I'll give you 2. And the patients are forever fighting about being allowed to have blood. So again, I work really hard on empowering the patients. Even though so with DBA, most people know to do extended phenotyping for sickle cell and thalassaemia. With DBA, I would say you should have the extended phenotyping as well. You should be getting fresh blood that's that's from the last 7 days, that the donor gave in the last 7 days or 10 days, and you should be getting the larger packs. And so I will often tell patients to write it all down and show me what they're getting. And I have written to blood bank managers around the UK about specific patients, and it's really made a difference to how the patients feel. So yeah, those are the issues that tend to come up with transition. And then mental health services. I'll tell you one more thing before we move on to the next question. There's working with this group of DBA patients about transition has been really interesting. So one of the mums said that one of the things that's difficult is a lot of teenagers, this is before COVID, a lot of teenagers will have got the chance to practice being independent. So they'll have been on residential trips, or they'll have been on sleepovers, or they'll have, been to another town with their friends on the bus. And when you've got a condition such as DBA or another rare condition or something that requires a lot of treatment, as a teenager, you hardly ever get to practice that, because to go on a sleepover, you'd have to have your mum with you, or to go on a residential, one of your parents would need to come. And so a lot of these kids miss out on the sort of normal growing up things, and then the transition to university is incredibly hard. So you've got different points of transition to think about as well.
Yeah. And then Claire from Sheffield. Hi, Noémi. Can you give us some comparative info on the 4 genetic hubs, turnaround time, EQAs, basically to help them choose which one they send samples to?
Choose. You are obliged to send it to your local GLH. And if you don't, like if somebody sent it to me, NHS England wouldn't pay for it and we'd have to charge you directly. Now, in reality, I'm not sure anybody's checking that. The labs are pretty good at refusing samples and sending them on to the right GLHs. So in terms of turnaround time, everyone's supposed to have the same turnaround time, and it's 12 weeks. And I know that sounds incredibly long time, but it's to do with the fact that we're in the NHS and that we haven't got enough staff to do everything we want as quickly as possible. If we had more staff, I mean, logistically, we can do it. Some people can do it in 24 hours, and that's kind of really, really pushing everything. And that's for very sick babies who are born in and end up in PQ, neonatal ICU, and with a clear genetic, usually metabolic disease. So there is the system to get that sort of 24, 48-hour result. Really urgent cases, so we might do things around prenatal diagnosis, so we can do it around sort of a week to 3 weeks. But it's literally to do with funding. And there's just, if we had, 5 extra people in the lab, we could do it all, everybody within 3 weeks, okay? My personal concern, of course, this is being recorded, so be careful, but my personal concern with the way it was set up with the 4 GLHs and who's in charge of deciding what tests are done and how the MDTs are done, etc. My concern as a clinician was that all of this was going to be led by clinical geneticists who, I don't mean clinical, I mean clinical scientists who are very, very used to the genetics, but will never have seen these particular genes and will not know the link between the genotype and the phenotype. And so my feeling was that it was very important to have clinicians on board. And so, but then Nandini's reservations would be like, well, that's all very well putting me in the MDT, but I don't look after these patients. I haven't seen many of these patients. So why are you asking, why am I being asked to give that clinical overview? But obviously, we have to grow that expertise. And so what we've done, and NHS England has facilitated this, and it's been absolutely wonderful, is we've got every 4 months or so a meeting between the 4 GLHs and NHS England, and we talk about, some of it is boring logistics like who's had trouble ordering what reagents or whatever, but some of it is really, look, I keep seeing these mutations in this gene and I just don't know if they're disease causing. And now we've started doing MDTs together. And the other thing is we're actually starting to share our variants, which means, and again, some of the labs are incredibly protective, which means we will have a spreadsheet with, these are all the variants we found in these genes. If you find the same one and you disagree about what we've said about it, whether it's disease causing or not, let us know. You could be right, we could be wrong. You might have more information at your end because you've got more affected family members, or we might have more information because we've done extra research on it. So it's critical we share all this and that we work together. We cannot afford, with these rare conditions, to get possessive and each want to do our own thing.
Thanks, Noémi.
Yeah, that's true. The thing I was going to ask, Noémi, what I find is, as a clinician looking after these rare anemia patients, is sometimes these patients would have had diagnoses years ago elsewhere. What sort of things we should be looking for in terms of getting a right diagnosis? I've been surprised by some of the you can't get hold of diagnosis.
Everybody who hasn't had a molecular diagnosis must be sent off for diagnosis now. And that's because there are some misdiagnosed patients. And, it's not about trying to blame anybody. It's about the fact that the technology we have now is just incredibly more precise and complicated than the technology that was available 20 years ago. 20 years ago, you had to test the genes one by one, and you had to send your sample to a different lab depending which gene you wanted tested. Most of the labs were not NHS labs, were research labs, and therefore there's no There's no quality control in terms of making sure that you've even given the right result about the right patient and all of that. I've seen patient letters with clearly wrong diagnoses, with, a mutation that is clearly just a general, like a variant that's found in the general population.
Yeah.
So we have to retest all of these. And like I showed you the genetic passport we've developed with DBA UK, I'm really trying to get patients to take ownership of their data and understand what mutation they have, and especially if you're told you don't have a mutation, because the number of patients, again, DBA UK weekend I've been to, and then the patients say, oh yeah, we've been tested and we don't have any of the genes. And so first of all, I'm like, everybody has every gene. You're talking about mutations, but okay. But how was it tested? Where was it tested? When was it tested? And there's people who were tested for 2 genes and that's it. And all we have to do is redo the test now. So we must absolutely be retesting everybody. And I
think that's the key. With the new NGS sequencing, you can do a lot more. There were things that we couldn't pick up years ago that we might pick up now. So I think that's the message. Okay. We've also got, have you seen a case of DBA with baby born with anemia at birth? I think.
Can anemia be at birth? It's a good question. I can't think of a specific case. I don't think that it would rule out DBA by any means. Yeah.
I think you need to think of it as a differential.
Yeah, I mean, like I said, there's also this transient erythroblastopenia of childhood, and essentially, if you do the bone marrow, it looks like DBA, but there's no genetic diagnosis. It has to be transient erythroblastopenia of childhood until proven otherwise. And so basically, if it resolves, it was TEC, and if it doesn't resolve, it's DBA.
Yeah.
But the other thing, is TEC wouldn't have the cardiac abnormalities, etc. So it's important to look for all those other things as well.
Okay. And Brenda, she's one of the genetic person in the lab. Do registries include genetic information on variants? And if so, are they freely accessed?
Different hospitals / research groups have their own registries which are not freely accessed. I mean, they'll be ethical because people will have signed a consent form to say they're happy for their data to be in there. And some, I'm sure they do include genetic information, but they're not. We don't have one registry with everybody in the UK. But DBA UK, the patient group, that's what they want, right? They don't really care about individual research groups wanting to keep hold of their information. That's not what they want. They want all the information shared, and they want the information shared with Europe, with America, etc. So, for example,
go on.
One of the things that the families will talk about is gastric issues, and that's not one of the things that is recognized as being an aspect of DBA. But maybe if you put everyone together in one registry, then you would say, oh yeah, there's a bit more of it than we thought. So.
Sorry, I was just going to say, Naomi, while we're on that point, one of the issues that we have is classifying some of the variants that we find, and I'm sure you've come across this. I was just wondering, on one of your slides, you've written the tests that you do phenotypically, or rather before it gets to genetics. So I was just wondering what we can look at in that respect that can help us classify some of these variants. Is there anything specific we should be looking for? Because for some of these variants, we really have no clue what to do with them. Yeah,
absolutely. So just email me, Brenda, and I can send you the list. I've also got I've taken the Oxford referral form, and for each of the conditions, I've done little arrows to say if we expect each of the things to be up or down or the same. Do you see what I mean? So if, I'm happy to share that if you'd find that helpful.
Thank you.
And please share your variants. Please, just email us and say, can we discuss? And, it's, again, like I said, it's not about we will know better than you, because you might have a variant that we've seen before and we've said it's just uncertain significance because we don't know. And then you'll say, well, I've got 2 affected family members who have it. And then suddenly, Kings have found one as well. And then suddenly we have enough information that we can change our classification. So.
Okay.
Please, let's do this and work together.
Thank you.
Brilliant. I've got another. Is there another person who's raised your hand? No? Brilliant. Thanks everyone for joining in. See you all soon.
Thanks.
Thanks. Bye.
Bye. Bye.